Okay, Zika. What is the current buzz? Let me see if I can go forward here. It's not, is it working? There we go, my little mosquito. Okay. So, my disclosures. I have nothing to disclose financially. However, I do feel full disclosure, I am not a Zika expert. I am helping out here. They needed a Zika speaker, and so here I am. I did do some consulting for Dr. Karen Sohan, where she was working in Trinidad Tobago. They had an epidemic there. She's an obstetrician, and they were looking for someone to help them before they were recommending termination. So I have a lot of the cases from Trinidad and Tobago to show you. Epidemiology. Constantly changing care. I mean, even in your syllabi that were just due 2 months ago, most of it's outdated. I mean, they update these numbers almost every month, and so the current lecture I'm showing you today, some of these numbers I updated in the last 2 days. You can always go to the CDC website to get the most current numbers. The Pan Am Health Organization also has a lot of informative data and current numbers for you. So our lecture objectives, we're going to review the virus, including the vector, transmission, symptoms, the current stats and trends. I'm going to provide an update for the CDC recommendations for testing and travel, and then probably what most of you are here for was to identify the ultrasound findings of congenital Zika syndrome. Now, the virus, most of us never even heard of Zika until about 3 years ago, but this is not a new virus. It's been around since actually the late 40s, early 50s, first described in Africa. There is an Asian lineage of this virus that multiple mutations must have occurred, that somewhere after about 2007, it started being associated with neurological complications, and that is the virus that we have seen in the Americas since 2015 that is causing all of these recent problems. Now, the vector of the virus is the Aedes species of mosquito. There are 2 types, the Aegypti and the albopictus. These mosquitoes do not only transmit Zika, but dengue and I cannot say that one, chikungunya, and yellow fever, as well as other viruses as well. They tend to like warm climates, low altitudes. They lay eggs near standing water like other mosquitoes do. They can bite during the day and night. And what's important to know that these mosquitoes can only travel about a half a mile to a mile. So when we talk about Zika coming to the US, it's not like they're flying 4,000 miles from Brazil to get here, okay? It's the humans that are bringing it over. Now, does that mean we have to worry about it? Well, these mosquitoes are here in the US, and this is the most recent map from the CDC website from the end of September, showing you these aren't actual numbers of mosquitoes or actual locations of the disease, but if the virus was here, where it could potentially spread to, because again, it likes these conditions, and these is where these mosquitoes have been reported. We particularly want to look at the blue colors because this is where the Aegypti mosquito tends to like, and that's the one that prefers humans and biting humans. So that's the one we have to be careful about. Now, transmission, as I mentioned, typically it's going to be a human that gets bit by a mosquito that bites other humans, and yada yada. This goes around and around. There are other ways that we can get Zika through pregnancy, from mom to fetal transmission, through sex, through blood transfusions. Theoretically, we can get lab-acquired infection as well. There's only been 1 reported case in the US from a lab-acquired infection, however. The infection itself, symptoms are very similar to other types of viral syndromes. Kind of the pathognomonic features for Zika in particular are the rash and the conjunctivitis. The conjunctivitis will look a lot like pink eye. The rash in particular tends to be these very small papules. They cover large areas and it does not itch. So that is something to pay attention to. Typically, the symptoms will begin about 2 to 7 days after exposure. They'll last for a couple days to a week. And note that only about 20% of people that are infected will actually experience some symptoms. So most importantly, 80% will not. Now, whether or not you have symptoms and express those symptoms or not, once you are exposed, you are considered immune for life. Now, the infection itself is not really that bad. It tends to be fairly mild, and so some potential consequences might be hospitalization, but that's very, very uncommon. Death is exceedingly rare. There's only been 20 total cases of deaths in all all of the Americas and only one case in the US that was in Utah, happened to be an elderly patient. It was acquired abroad, and for some reason his viral load was 100,000 times higher than the average seen in other infected persons. So that was just kind of a really rare case. Other potential consequences, we've all heard of Guillain-Barré. It tends to be more common in adults and in males. And this is kind of where it's a super aggressive, your immune system kind of takes over. And so once it gets activated by the virus, it now starts attacking your own peripheral nerves, tends to start in the legs, moves up to the arms and the face, and it affects the chest. It can cause breathing difficulties. Outcomes, most people will recover fully, but it can result in near total paralysis and does have about a 3 to 5% mortality rate. Total numbers in the US from Zika-related Guillain-Barré are just about 15 and 52, including the US territories. Congenital Zika syndrome are the one that we hear the most about. These are the birth defects that involve the both central and peripheral nervous system, the eyes, the joints. The reported risk of getting the syndrome once the mom is infected with the virus is only about 1%. I think that's important because I used to think that, oh my gosh, once mom tested positive for Zika virus, that all of these fetuses would be infected. However, it's only really about 1%. That risk of the fetus being infected or having consequences is going to be increased if the mom happened to be symptomatic and if that exposure was earlier in pregnancy, which makes sense to us because that's when embryogenesis occurs. However, note that that risk is not restricted to just the first trimester. This was an interesting paper published in The Lancet that was looking at the baseline prevalence of microcephaly in neonates and then with timing of exposure in the first, second, and third trimesters. And we noticed that while the risk ratio goes down, it still exists if they were exposed in that second or potentially second, third trimester. So it's not just with that first trimester. So epidemiology, I feel like Kai Rizdal and say, let's do the numbers, right? So epidemiologic update in the Americas, you will see that the lighter yellow colors are where it was they first occurred. That was back in 2015. The darker colors are more the countries where we had more recent infections going on. Good news is there have been no additional countries or territories since epidemiologic week 44, so that's about November of 2016. No new countries have been reporting Zika, at least in the Americas. Looking at the overall numbers, again, this is different from your syllabus because this was updated yesterday. We have now about 48 countries where they have the mosquito-borne cases, about 5 countries with sexually transmitted cases. In your syllabus, it says 26, and we now have 27 countries with the congenital Zika syndrome. Guyana was the most recent country to be added to that. These are the total number of confirmed cases, about 250,000 so far, and about close to 3,700 of the Zika syndrome. While those numbers seem high, if we look over the course from 2015, and here we are in 2017, we know that there is a marked overall decrease in the number of cases. So we are on a very good trend of decreasing numbers, with the exception is that in Central America, Costa Rica is actually increasing, as well as there's some specific regions in South America. I want to point those out, noticing again, here is 2017, so to make this a little bit bigger, Bolivia, Ecuador, and Peru, as well as Argentina. Those particular countries are actually seeing a rise in their own countries' numbers of the Zika virus. Here on the homeland, these were the states that had, in 2015, that had reported cases of Zika. You'll notice in California, and most of those were travel-related from Mexico, that we had only about 61 cases in the mainland of the US. In 2016, we were up to over 5,000 cases that you can see again with the dark blue numbers, but here we are in 2017. So again, these numbers are decreasing. Here I've kind of broken it down by year, 2015, 16, and 17 from the mainland and the US territories. We will look again for this year, most all of these, at least in the US, are travel related. This one case that is local mosquito borne, again, just got in the literature somehow in the last couple weeks since your syllabus was published there. And most of the cases in the US territories are actually from mosquito borne, so people aren't going and bringing it to those countries. Most of our cases here were from last year in 2016. That was that one laboratory-acquired case that I was talking about. And the local mosquito-borne cases, those 224 cases, almost all of those, in fact, all of those came from Miami-Dade, Florida, and Brownsville, Texas. So most of those 218 were from the Miami-Dade County in Florida. This is a map of where that location is. As of June of this past year, June 2nd, the caution travel advisory has actually been lifted. They do recommend, though, that if you live there or travel to, that you want to practice mosquito bite prevention, use condoms, and if there was any possible exposure between this time period when it was first reported on August 1st of 2016 and June 2nd of this year, anyone with symptoms should be tested, and those planning to conceive should wait. Women should wait about at least 2 months, and men 6 months, because the virus is believed to last longer in semen, actually, than it does in blood. Now, in Brownsville, Texas, there's only been 6 cases. And again, this is new in your syllabus. It was still, there was an advisory travel caution just a couple weeks ago when the syllabus was due, but now very recently, they have lifted that with the same exact cautions if you happen to live there or travel there, or perhaps in that last 10 months that you should wait if you're planning to conceive. Now, some more numbers regarding outcomes of pregnant women that have lab evidence of Zika infection. Again, this is in the mainland and in the territory. They're looking at total cases and then completed pregnancies with birth defects, with or without, and then how many live-born or pregnant. So basically, this is even less than the 1% risk, right? And that's because a lot of these are terminating when they hear that they have laboratory evidence, which is really unfortunate. It's been about a 15 to 25% termination rate, so that's why those numbers are a little bit lower. So testing, how, who, and when. The main way that we first started testing for Zika was with this NAT test, which is the testing for actual Zika RNA, and that can be found in the serum, urine, or an amniotic fluid. It can be positive within about the first 2 weeks following the onset of symptoms. The bad news is that a negative test does not exclude Zika virus. IgM, which is serum, so that's your antibody response to the virus, typically will be positive within the 4 to 14 days after exposure. It can be positive up to 12 weeks or possibly longer. So the bad news is it cannot determine the timing of infection prior to the current pregnancy. So again, you can have those antibodies floating around from potentially maybe you were bit even 6 months ago. Some more specific tests are these radioimmune assays, the PCR and the PRINT tests. The FDA has issued these for emergency use authorization if it's presumed positive or if there are any sort of equivocal or inconclusive IgM results, and they're only distributed to certain qualified labs. So you'd have to find out from the CDC which labs actually have these particular tests. Now, who should be tested? This was recently updated in the CDC just this past July. They've come up with 4 categories of at-risk individuals, but first we need to define what they mean by possible Zika virus exposure, and that is living in, traveling to, or having unprotected sex with someone who lives in or has traveled to an area with risk of Zika virus infection. So our first category is anyone with possible exposure with symptoms. So they have to have the symptoms. Any symptomatic pregnant woman with possible exposure. Any asymptomatic woman with ongoing possible exposure, and the operative word here is ongoing, because with this most recent update, they said that if it was not ongoing exposure, routine testing is no longer recommended. And prior to this past July, we were testing women even if they had not ongoing exposure. It was a one-time exposure. You can then go for these symptomatic and asymptomatic pregnant women. They have these very nice algorithms on the CDC website. So I'm showing you the one, this would be for symptomatic. They really paid a lot of attention saying every single encounter that a pregnant woman has with her provider, she needs to be asked, hey, did you travel to any Zika in place with Zika, possible Zika exposure? Did you have sex with anybody that had possible Zika exposure? Because this is really how we want to catch these patients. So these are the ones with symptoms. You want to test them as soon as possible through the 12 weeks after the onset of symptoms, and they're going to test with both the Zika RNA and the IgM, and then there's algorithms what to do from there. With the asymptomatic patients, again, gotta ask, because only 20% are going to have the symptoms, 80% will not. So again, it's only those with ongoing exposure. They are to be tested 3 times during pregnancy, and it's only for the Zika RNA virus, and then it tells you what to do from there. The fourth category was pregnant women with possible exposure and fetal prenatal ultrasound findings that are consistent with congenital Zika syndrome. If you see findings on ultrasound, then you want to follow that lab algorithm as if they were symptomatic, even though they may not be symptomatic. So, what do we look for on these exams, and how often do we do them? Per the CDC, ACOG, and the Society of Maternal Fetal Medicine, they say we should be doing serial exams about every 3 to 4 weeks if there is any sort of evidence of maternal infection, and it can also be considered for women who have traveled to endemic areas and have no evidence of the infection, because we know it can be asymptomatic. Now, what we see has really been based on observational studies in the literature since early 2015. There are no universal Zika scanning protocols to really optimize sensitivity for these findings. The International Society of Ultrasound and Obstetrics and Gynecology did have something saying these are the minimum number of images you should get to identify CNS abnormalities. But really, I think what's important is to know what to look for and when to look. So, congenital Zika syndrome involves intrauterine growth restriction. We will see anomalies in all of these different structures. Let's start with the brain and skull. Probably overwhelmingly, the most common thing we will see is cerebral volume loss, evidence of loss. So that's going to result in microcephaly. It's going to result in enlarged subarachnoid spaces, calcifications, subcortical, periventricular, even in the cerebellum, ventriculomegaly. And then we're going to have some other abnormalities that we're going to go over as well, but particularly in the posterior fossa. Most of the hubbub, though, has been around microcephaly, right? In fact, I used to think all I was looking for when they said possible Zika exposures, I just look at the head circumference and say, oh, there's no microcephaly, I'm done, I don't need to look anymore. So let's talk about microcephaly. Microcephaly is actually found in about 2 to 12 cases per 10,000 live births in the US. This would be kind of a typical head size. This would be a baby with microcephaly that is considered 2 standard deviations below average, and then 3, which equates with about a less than 3rd percentile, okay? Because that's just how you need to think about it. It's severe microcephaly once we get 3 standard deviations below average, which equates with about less than the 1 percentile. Now, what we need to keep in mind that the CDC definition of microcephaly is a postnatal diagnosis. And as a postnatal diagnosis, it has to be more than 2 standard deviations below the mean, which is again less than the 3rd percentile. And on the CDC website, they even have a YouTube video showing pediatricians how they should be exactly measuring the fetal head circumference to make this diagnosis. Now, the in utero definition of microcephaly is really not as clear because, again, it really wasn't defined that way. But what we do know is that we tend to undermeasure the head circumference. And in this one paper of over 3,000 cases, they said that we underestimated the head circumference measurement to the actual head circumference measurement for some reason, particularly in male fetuses and when there was vertex presentation. In this study of 20 cases, even when we thought on ultrasound in utero that we were somewhere between the 2 to 3 standard deviations below the mean, 90% were normal at birth. So somehow we're really kind of overcalling this by using these standard deviations. Now, why could that be? I don't know. I kind of was looking at a case that we had recently of a 3rd trimester pregnancy that was vertex presentation. I thought, okay, well, I would have thought that these were pretty good measurements. But note how when it's vertex, you kind of get this dropout at the extremes, at the forehead and the back. And so maybe really the measurement should be more like that, but we're only putting around what we think we can see. I don't know, maybe that's part of the problem. The Society of Maternal Fetal Medicine in February of 2016 published a statement about ultrasound screening for microcephaly. So not for all of congenital Zika syndrome, just about microcephaly. And knowing that we do have this known underestimation, they said if we want to be certain, then we're going to have to use more than 5 standard deviations below the mean. And that's 100% like certainty, like way, way bad. If it's more than 3 standard deviations below the mean, then we're going to diagnose microcephaly. But if it's only 2 standard deviations below the mean, then you should probably look for other evidence that might tell you that Zika syndrome is going on. So again, we're using a greater standard deviation than they use to diagnose the postnatal diagnosis of microcephaly. And they state that if your reporting package only reports the percentile, which is like what mine does, then they actually gave a chart that you can go to on their website so that you can convert that to standard deviations. There was this nice meta-analysis that came out in May of this year that they were trying to see, if we were using 3, 4, 5 standard deviations, how well were we at diagnosing Zika virus infection and microcephaly. Note that all of these 9 studies, none of them actually included Zika-infected patients. They were just using other studies of head circumference measurement. And while it's true that we'll have very high specificities, the higher we get away from that standard deviation, and perhaps using 2 standard deviations, we would capture all of those fetuses. We're going to have a lot more false positives. So perhaps there's other things we should be looking for, and thank goodness there actually are, which is why I really like this paper that just came out in the Lancet of this past summer. And it gave really 2 great take-home messages. The first was about timing of when we see these findings. Of their 14 cases, it was a small group out of Martinique. They had 14 confirmed congenital Zika virus cases. 4 of the 12, so they had 12 that had ultrasounds early on between 16 and 20 weeks, and they only saw abnormalities in about 1/3 of those and 4 of the patients. All of those actually terminated. 2 more joined the pool. They found about 90% they could see of the abnormalities between 20 and 24 weeks. Once you got past that, then they could see 100%. So their take-home message was the public health efforts should really focus on scanning between 20 and 26 weeks gestation. I think this is helpful, at least knowing that if we don't see anything by that time, we don't have to keep scanning, 32, 34, 36, that we expect to see something. What the bad part about this is usually that's around the time when you can offer somebody an elective termination. So it's just up against that window. What they also looked at were the other major brain anomalies that were identified. And if we look here from the most frequent to the least frequent, microcephaly was only seen about 64% of the time. So if that's what we're looking for to make the diagnosis, we're going to miss a lot of cases. There's a lot of other things that we should be looking for. And they concluded that the assessment of just head circumference measurements for microcephaly is not an effective screening tool. We need to look at other things, which brings me back to this paper in Radiology that came out of our colleagues in northeastern Brazil, where they obviously had a lot of congenital Zika syndrome going on. They had 17 confirmed cases, 28 presumed, and you will see all the different abnormalities that occurred intracranially. Again, volume loss being seen in 100%, ventriculomegaly, and so forth. So now I'm going to show you some examples. These were cases from Trinidad Tobago, just showing you kind of the typical ventriculomegaly. Here are the large subarachnoid spaces, right? So right here, you're just seeing too much space between the cortex and the surface there. Here's another example right there. We're seeing the subarachnoid spaces are too big, and it looks like there's a bunch of junk in there as well, which was one of the findings that was reported in that radiology paper, which they called heterogeneous material in the region of the confluence of sinuses. But that's kind of demonstrating the same thing that we're seeing right there. Here's another example. We're seeing some blood vessels going through there, but there's all of that material up there. Here's an example of ventriculomegaly, and then some lissencephaly, so kind of a smooth brain, which we see the major fissures just look too big, right? It just looks like a really smooth brain. You can also see polymicrogyria that you see right here with all those little undulations occurring. The calcifications tend to be cortical and subcortical. They're identifying some over here, but all of these are our calcifications that we will see in the brain. Here's another example. We have ventriculomegaly, those enlarged extraaxial spaces, and then all of these calcifications. And here's an example of some cerebellar calcifications. Now note, these are different than the calcifications than we tend to see with the torch infections. Usually with torch, this was a case that I just had of known CMV infection. infection where we're typically looking in the caudate nucleus and the thalamus, so they can occur there with Zika, but that's not where they characteristically occur. So just so you know, when they talk about intracranial calcifications or thalamostriate calcifications that occur with CMV infection that we're seeing right here, those aren't the ones that we're talking about with Zika. We're looking in the cortex. Callosal dysgenesis, seeing an absent cavum, that colpocephaly that we saw earlier on the 3D images. Here's a case of a complete agenesis of the corpus callosum with the teardrop-shaped ventricle. We're seeing these cystic structures, which is really a dilated third, and the interhemispheric or dorsal cyst. This is an example of porencephaly, where we just have some destruction of the brain that's communicating with the ventricular system. And then some cerebellar anomalies that we're seeing here, as well as this is an MRI out of that paper from Radiology showing a very small vermis as well as a small cervical cord. And what I want you to also see is this abnormal head shape and kind of the sloping of the forehead, because abnormal head shape has also been described with congenital Zika syndrome. They tend to have a collapsed appearance, overlapping sutures, and redundant skin folds, as evidenced by this picture right here. Here's an example from Trinidad and Tobago that my colleague sent me here, showing those overlapping sutures. Craniosynostosis can also be seen, so it kind of looks, you don't see all those sutures tend to be closed and they kind of tent up and kind of peaked up there. Here's another example from the Radiology paper, which on bone windows you can really see those eversion of the sutures over there. Ocular manifestations, I have these in two categories because these are really the ones that may be seen on prenatal ultrasound that you need to be aware of. Cataracts, I'm showing you what normal lenses look like. Cataracts are just going to be really echogenic, right? And they're going to kind of fill in those lenses. Here's an example that I had. This wasn't a Zika case, but it was just a case of fetal cataracts to show you what that looks like. Small orbits. So if you think the orbit is small, if you're suspecting it, you can measure it from the outer lateral and medial margin, and there's nomograms that you can turn to look for what is normal. Club feet, I'm showing you normal. When we have a coronal image of the tib-fib, we should be seeing short axis views of the knee and the ankle cartilaginous structures. Here we have the classic club with the foot bent in that way and the other foot as well. Arthrogryposis is where you're seeing clubbing, but more than that, you've kind of got the joints, they don't bend, they just kind of stay out in this very rigid, extended position right here. And another example, you can even see this in the first trimester. Occasionally you can see arthrogryposis that we're seeing right here. Treatment, unfortunately, there's no vaccine for this. This is, you can treat the acute symptoms of the infection with Tylenol. Important that they don't take Motrin or nonsteroidals because of the increased risk of bleeding. So prevention is really about avoiding travel to these countries. You can go to the CDC website and you can look at your individual country and it will tell you what the risk is over there. If you have to travel there or if you happen to be in an endemic area, you definitely want to protect yourself from mosquitoes, use repellent, nets for sleeping, eliminate the standing water outside your home, and you have yet another reason to practice safe sex with condoms. Okay, so in summary, we know transmission is mostly from mosquito bites, but it can be these other routes as well. Good news is numbers are decreasing in the Americas except for these specific areas. So if you happen to be traveling there or your patients, symptoms are typically mild. And again, death is very, very rare. The congenital Zika syndrome, only about 1%. So even if the patient tests positive, only about 1 in 100 will that fetus develop that syndrome. You want to test anyone with symptoms, pregnant with ongoing exposure, or anything suspicious on ultrasound. Then if they have the infection and they're asymptomatic, but there's travel, you want to do it about every 3 to 4 weeks, with the optimal window being about 22 to 26 weeks. Probably most important thing I want to send home is that microcephaly is only one manifestation of this syndrome. We want to look in the brain for all of these other things, as well as the orbits for cataracts, club feet, arthroposis, and IUGR. If there's no other findings, probably best to use that more than 3 standard deviations below the mean, and then 5 to really be certain. The CDC, again, you want to go to this. It's an invaluable resource. They keep updating this almost on a weekly basis, but protection is really paramount. You really need to take that protectant with you so we will get rid of all of our mosquitoes.